these are generally very sick patients. Some of them need scans quickly, and we have to go through a process of ordering the scan and transporting the patient. That can be difficult. Some of these patients have ventricular drains. Oftentimes they're on the ventilator. So there are a lot of potential problems with moving a patient, and a portable unit definitely is something that would be very, very helpful in getting rapid assessment of a patient that could be changing very quickly. It's a big nursing issue, really. Generally, the surgeon or the provider is ordering the scan, and that is calling in a number of people to move that patient. And that means nurses that are taking care of other patients are going to come over, help to transport the patient from their ICU bed over to a transport bed, and then depending on how many lines in the ventilator, you might need respiratory therapy to come. So it's a rather large production. It can take sometimes 3-4 people just to move a patient. Now the patient is moved from their bed over to a transport bed, and then from a transport bed onto the gantry of the scanner, and then back and then back. So there's lots of room for potential error or problems that can occur with that. So it's not a small ordeal, that's for sure. And the thing is, you know, it's done often. We have to get scans quite well. After the order is placed, it can take, you know, just to mobilize and let everybody know. I would say you're looking at 35-40 minutes, depending on the patient situation and how far the scanner is from the ICU. That's another consideration. Sometimes it's on the same floor, other times it's multiple floors down, and then you have the issue of accessibility from the scanner. I mean, is the scanner available? Are they serving trauma from the ER or other patients in the ER? Around 2006, our involvement, and then evolved into actual clinical trial in Nashville, where we did use this in the ICU. And immediately, as with any kind of new technology, we reach a point where questions are immediately asked through clinical utilization of new product. And so we've been very fortunate to help with the evolution of the scanner, of the protocols of moving the patient or moving the scanner into the room and going through the process of actually acquiring the images. So my involvement has just been an involvement out of a curiosity for innovative technology, and I think that that's what this really represents. An ability to get information quickly in the neurosurgical setting is just what we have to do. Yeah, you know, there's a nice protocol that's put together in terms of how to move the patient into the scanner, how to direct the scanning process, and I think with that education, it's a very fluid process. And I've seen these scans done, you know, 6-7 minutes, under 10 minutes certainly. But it's like any kind of new technology that you introduce into a hospital system or an ICU. There's a period of time where you learn about and embrace what the protocol is to actually execute the scan. But it's not a lot. It's certainly not anything close to what you go through to move the patient down to the scanner like we talked about just a minute ago.
Okay. So that's bedside in the neuro ICU unit.
Correct.
Compare that to, say, a traditional transport down to radiology. What would be involved in that as far as the workflow?
I mean, very similar steps in that the patient, we first have to even more so make sure that the patient can safely tolerate much more robust transport. And unlike with a portable CT scan, a patient gets placed onto a portable stretcher. These beds are usually less portable, so another nurse and a tech will bring a stretcher into the ICU room. And again, if someone's on the ventilator with assistance of a respiratory technician, the patient will be transferred from bed to stretcher. You know, even before that happens, the nurses have a certain safety checklist, right? They go through all the medications the patient is on, make sure there's adequate supplies of pressors, you know, whatever continuous infusions they're on, make sure there's an oxygen tank present, make sure the appropriate equipment to ventilate the patient is there. Once all of that kind of rudimentary supply checklist is done, then a patient is wheeled out through the ICU to the patient transport elevator. At least at our institution, goes 5 floors down to the first basement level where the radiology suite is. Patient's wheeled a couple hundred yards down a hallway, and then that patient positioning is repeated. So a patient is taken off the stretcher onto the CT scan bed, CT scan is acquired, patient placed back on the stretcher, reverse, and then back on from stretcher into bed. So there's just a lot more patient transfers and a lot more potential for dislodgement of lines, tubes, and elevated intracranial pressure with that system.
So with regards to the xCAT IQ and a point of care cranial CT, your ability to make that order, what are some of the patients that you would think would find clinically beneficial to this type of imaging device?
Sure. I mean, most of the time, it's patients that we have some concerns about transporting them down. So more often patients that are ventilated, just because any time there's a ventilated patient and you're doing 3-4 transfers between bed and stretcher, there's a chance that that endotracheal tube can become dislodged. So patients that are ventilated have a lot of support devices, and then where we want to get information relatively quickly, because a portable scanner does have the advantage of being faster acquisition time because there's not that transport involved. So when there's an acute neurological change and we want to know why, and when we suspect that it's due to, the most sort of common things that we see are, new intracranial hemorrhage, new and worsening midline shift due to cerebral edema, new hydrocephalus, things that are relatively readily visible on CT scan.
Excellent.